welcome back to the second episode of Code Brew. I'm Joe King, and I'm here with Lukewarm.
Hey everybody, this is Luke.
We're spilling the tea on nursing life. Invite you to stay caffeinated and stay curious with us as we get started. And just a recap from last episode, we went over just kind of why we started this podcast and why we, we're really interested in building a community to create a safe space for people to ask questions and dialogue with us about things that they're seeing out there in the wild, And so far, we've gotten some really positive feedback. Very excited about that.
I was kind of impressed. Other countries?
Yeah, we did. We have another country. Germany is on our map. That's very exciting. We got about 8 states right now. People represented in 8 states. And it's not just where my parents live, just so we're clear.
Or mine. Actually, it's not where my parents live.
Oh, yeah. Your parents haven't listened to it.
They haven't listened to it. And my mom's a nurse, so that's great.
That's amazing. So we need to talk to her. We need to get her in.
Send her the link over and over and over again. She did say if she wanted to listen to it, how would she do that?
Well, my dad, he didn't listen to it until basically I was on my way here. So today. But today is his birthday, and I did like
that's his gift.
Yeah. That's his gift is the podcast. No, I think I'm gonna buy him some rum, but anyways.
You've finally done something with your life that's
They did say they were proud of me. They liked it. And they said really nice things about you. And I was like
finally.
I was like, I don't think y'all are getting the right vibe about Luke, for sure.
Luke.
No, but very excited that people are interacting with us. We're proud of what we're creating here. We're really excited about it. Even got some positive feedback from some of our leadership at the place where we work. A lot of coworkers too, of course. They're excited about it. I even got an idea from one of my bosses.
Yeah, I kind of thought that.
I kind of like the guy.
When they said that they were saying like, oh, if you start a podcast, like you should talk about preceptors and what that looks like. Not, oh, I was listening to your podcast and I think your next one should be on like the orientation process.
So like that's the
confused me that he already listened to it.
Yeah. So let's call him. What are we going to call him? J-Dog. Let's call him J-Dog. J-Dog. We are going to look at precepting at some point.
I can't.
You can't? J-Dog, you don't like it? He's probably going to hate it. He's going to laugh, though.
It's great. I love it.
No, we're going to come up with different names. And I guess we should explain that, too. We're not actually using our real names.
You're not Joe King?
No, my parents did not name me Joe King. Although, I'm sure they love it. Your parents didn't name you Lukewarm? It tracks.
It's fitting, yeah.
No, you're more of a spicy. If I had to choose your name again, I'd call you like Spicy Nugget or something.
Oh, gross.
Spicy chicken sandwich.
Stop. Okay. Let's get
Let's go back. Let's go back to the show. Okay. So housekeeping, as always, the disclaimer. I'll read it real quick. So the views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational entertainment purposes only and should not be considered medical advice. Okay. So on to today's topic. We are diving into the lessons that nursing school maybe didn't prepare you for and how you can be successful in the real world, out there in the wild. I like to call it in the wild. I don't know, the real world. I feel like everything's the real world, but out there in the wild.
It's definitely a big transition. We talked about that yesterday about the multiple different types of nurse and nurses, and they said there's 2 types of nurses, and you cry on the way to work or cry on the way home from work. And then I had the friend that said she was a 3rd type and cried on the way to and from.
She's still crying.
Actually reached out to her last night, or a group of them. Thought it was funny. But what does nursing school not prepare you for?
I think it's important. Let's talk about what it does prepare you for. Yeah. So I feel like, first of all, we do not have any intention to disparage nursing school. I feel like nursing school is doing an excellent job of preparing you to be just safe enough to, be able to function. However, it's impossible to truly prepare you for the real world of nursing. And once you get out there and you have the weight of this license sitting on your shoulders, it's it's challenging. It's very challenging. And
I think it's important to say that, like, so provider, like a doctor, can consult like another doctor, another service line. So like cardiology can consult neurology or pulmonary, and they can consult all these services when they don't know something or need a second opinion or somebody to manage care for, a different system.
Yeah.
And, with nursing, you can't do that. So, we talked about nursing consults.
Like you can't. The
so
culture is that you can't.
We talked about nursing consults and stuff like that, but there's, there's more like a generalized all-inclusive education, but like understanding your resources and preceptors and charge nurses and house and policies and, trying to take all of that in, while you have a good understanding of patho and medications, that practical knowledge of implementation and putting to use when you've only done it in a clinical setting. I mean, I think about like current students right now. You're responsible for, and loosely responsible for, a patient and
a single patient,
some of their meds, and some of their assessment. And while I'm asking you questions and you can answer them, you don't really have to think about all of that communication between providers and things that we're looking out for with various medicines based on multiple comorbidities. I mean, like, you think about that when you go home and like when you do your paperwork or your clinical packet, but throughout the day, like, you're prompted to think about it. But now add 4 more patients,
right,
and add complete care, so that's where it gets really difficult.
Yeah. I mean, it really does. I mean, it's, you don't learn prioritization. I mean, they can give it to you in, they can tell you, well, like, life is more important, or like we can talk about things like the ABCs where airway comes first or whatever. But when it comes to like simple prioritization, like the even the smallest decisions you're going to make, because you're basically always going to have something on your plate when you get on the floor, and you're
10 things on your plate.
No, 100%.
Okay, so not 15, one thing. That would be really easy to prioritize.
No, but for sure. So there's always going to be something that you're supposed to be doing, and you're going to have to make very small prioritization decisions a million times a day. Like, which one should I do first?
I always write out, I mean, still 15 years into nursing, I write out a list of like the time frames that stuff needs to be done and the meds given, interventions, and then like just like a general list over to the side of times like these things have to happen, but they can happen like sometime throughout the shift. Right. And even though I try to plan and I try to have structure, like I know like 100 things are going to come up that are going to get
in the way,
kink into those plans. Yeah. But I've got all my check boxes and everything's lined up and it will get done, and we can delegate and ask people to help out, but just because
delegation, that's a whole other topic. Oh my goodness.
I think it's going to happen at 10 doesn't mean that it's going to happen at 10 or maybe even 11.
Yeah. So, I mean, we're going to try to get it within the window of between X and X, like between 10 and 11.
But kind of like, what can you put off? Right. So what are those things that you can
and you have to figure that out. And a lot of times that's not something you're going to immedially know as a new grad nurse what you can't, and you're going to get bogged down by that structure that's, you're going to feel like everything's late. And it probably will be in the beginning. Everything will be late.
I've heard people say that newer nurses, a lot of them function as like task nurses. So like it's everything is just like a time related.
They don't have the space in their brain for the critical thinking, which is kind of our next thing.
We haven't taught it. So we've taught it in some capacity, but we need to, every single thing, not to start early on the orientation process, but like, with orientation, like every single moment that somebody's in orientation or clinical, like, somebody needs to be there and not just like, oh, they're just giving protonics. Like, you need to be asking them questions. Like, why are we giving this med? Right. What is it for? Right. What's the indication in the hospital? Why is everybody on it? There should be.
Yeah.
Yeah. I think we get, I think we get comfortable thinking, oh, they're just going in there to give a med. I don't need to go with them, rather than like,
no.
you know, the preceptor looking at it as like a learning opportunity, you know, like they're just adjusting a drip in the ICU. Like it's fine.
I had a paramedic student one time. I think I maybe told you this before, but I had a paramedic student one time that he was green as the day is long, right? So he was brand new, and we were giving meds one time, and I'd given him meds. Okay, hey, we're gonna give the morphine. Hey, he started the IV, did a great job, and starting the line, and then, you know, I was like, okay, we're gonna flush it. Here's some morphine. We're gonna give him. I think it was a guy that had been like shot in the ankle or something like that. It wasn't like a really or somewhere in the leg. I can't remember. I don't remember the details of this patient, but it was like a pretty low speed trauma patient. But one of the things we do for every trauma patient, and for those of us that don't work in the ER, is we give them a freaking tetanus shot, you know? And so I handed this kid a tetanus shot. I scanned it. I put in, you know, the expiration date and everything. I put a needle on it. And I said, here's the tetanus shot. And this kid just puts it right in the IV like it ain't no thing. Like it screws it right on and pushes it. And I'm just sitting there looking at him like, oh my God, what just happened?
Well, I mean, in the hospital setting, I
was standing right there.
But we've actually flipped to, what is it, the infit, like, you know, for Dopphoff tubes and stuff.
Oh,
because you could actually attach a syringe to like Dopphoff tubes and G tubes and all that kind of stuff.
And put things in there that don't belong.
So we actually have a different adapter to where now like syringes cannot attach to them.
And it's crazy that we had to do that, but we had to do that.
Well, yeah.
But I mean, it's easy. I mean, people just, they did these tasks, and I mean, you could look somebody in the face. I looked this kid in the face and said, this is a tetanus shot. I put a needle on. I'm pretty sure I even put an alcohol prep in his hand, and he still put it in the IV. And come to find out, just so you're aware, there's not a lot of human data about what happens if you accidentally give somebody an IV tetanus shot, but there happens to be a little bit of veterinary data, and that's all we could pull from whenever I called the pharmacy that day. That was years ago.
I'm glad you followed up on it.
Oh, I did. Okay. I was like, what are we going to do about this? Oh my gosh, it was...
What else does it prepare you for? I mean, I felt like I knew all of the...
I think critical thinking...
signs. I knew all of the Burdensky's, and, you know, like I knew all of the signs. Cranial nerves.
Holman's, Babinski.
What is that? Cranial nerves, antidotes.
Oh gosh, cranial nerves.
You know, oh gosh, there's, yeah, I don't know.
I'm thinking about.
I would definitely have to refresh right now.
I was about to say, because I can't remember the cranial nerves.
There's 12.
Yeah, I think there are 12.
Okay. If anybody wants to call in and review those with me, that would be awesome. Perfect.
Yeah.
Or a memory trick. Love mnemonics.
Yeah, I love mnemonics. That is something we're gonna do. We're gonna have as a one of the ideas for an upcoming episode will be the memory tricks that you use for, you know, all sorts of things. So, and if you have any that you've made up yourself, please let us know, because we would definitely use it on the show. But
you know, students know a lot, that, you know, they have a lot of information, and you know what's interesting is, yeah, I said this before, but you know, I'm reading their assignments, I'm reading their patho, their meds, contraindications and stuff like that. And every week I'm like, oh my gosh, like forgot about that, you know, like, so like the knowledge is strong.
Teaching makes you a better nurse, like being a preceptor.
Oh, for me too. Like
it does. It makes you a better nurse. Like it refreshes things that you haven't thought about in a while. And that's one of the things I was actually just having that conversation maybe yesterday or maybe this morning. I can't remember, with somebody else. And I was like, you know, yeah, you're a great preceptor because you know what you're doing, and the things that you say will make you nervous about being a preceptor. Also,
you're willing to go out and find the answers.
Yeah, like because you don't know the answer is why you're afraid to be a preceptor. But you're gonna find the answer, and you're also gonna show the person that you're orienting, like, you know, how to find the answers, like what their resources are, and then, you know, and also you're gonna put aside your pride and say, I don't know, and go find it. So anyways, so moving on to things that nursing school really doesn't teach you, and the things that are pretty glaringly obvious. The prioritization is one thing, but I think the critical thinking is one of the things that you really need experience.
It's there though. So like,
it is there,
so critical
but it
thinking
needs to be
there,
cultivated.
But often walk through things. I feel like in nursing school in like a singular setting. Like the person doesn't have a complex history. Like this is just some 30-year-old guy that came in and he had a heart attack and you know, there's nothing else wrong with him. He's a lumberjack, you know, he lives his perfect life and eats great. And it's not that simple. Rhino. But then, you know, like I'm getting report here in Kentucky.
Mm-hmm.
And, you know, I know that it's, you know, cabbage, MI times 2, stents, hyperlipidemia, hypertension,
chronic kidney
disease. And that just almost seems like a recipe for the average patient here. So when you're having to learn like that,
how all these things work together.
Well, like, it's like, well, hold on. Like the cardiologist controlled diuretics like in the last patient, and why? So like now I'm calling the cardiologist. I'm saying like, oh, hey, or kidney injury, like renals consulted because we don't want to damage the kidneys more, right? Like, but that thought process, you know, so how to create that, because it's no longer in a, what is it, like a box, you know, like it's no longer like the singular,
in a vacuum. Yeah,
it's no longer in a vacuum.
In a vacuum.
Yeah.
Yes, I mean when they have like 1 or 2 issues, whereas like, you know, once you get in the wild, the patient has, you know, at least 15 things on their medical history, and you're basically dealing with all 15. Like you hope one of them is like an ankle fracture when they were 10, but it ain't. You know, like there's a million things you have to deal with, and you're tackling all these challenges at one time, and then you add on all their meds who are working against you. You got to take a med for this, you got to take another med to fix what this med does, and it gets really challenging. And then you add the high speed component, right? So you have a patient who's suddenly deteriorating, and you have to critically think, and you got to do it really fast. Now, I will say this. I mean, one of the reasons that Luke and I have positions that we have, like being house and being a rapid response nurse, is because some people need help with that critical thinking portion and doing it quickly. I mean, and so we kind of.
But you're not just gonna have that. Like,
no, you don't always have it, and we're a resource. But we, you know,
you have to cultivate it and grow it.
Yes, and that's one thing. You know, we really enjoy. I think both of us really enjoy teaching, even in those moments where we can, you know, hey, this is what we saw, this is what we were thinking, and you know, and cultivating that critical thinking piece. It doesn't just happen with new grads; it happens with people at all skill levels, because you know, we want our nurses to be strong, the nurses that we work with, the nurses that we see every day. We want them all to be strong and feel like they're thriving and the best that they can be.
What is your suggestion? So like if there's a new grad or a newer nurse that wants to work on critical thinking, and okay, they've got the residency program and they've got a preceptor, but like what is your suggestion to them to really like help with that?
So I think a lot of it comes with exposure, you know. So I want
a ton of it. A ton of it comes with exposure.
I mean, I think it's impossible. Like it's not something that happens overnight, and it's not going to come out of a book. It's going to come from repeatedly being exposed to situations where you know are watching other people and how their process works. I mean, and you're discussing it, and you're seeing. I mean, I think one of the things about critical thinking is like if you have to figure out what the average patient looks like, so that you can see,
to know what normal is. Like you need to know what normal is to know what abnormal is.
And I think that's one of the strong points for nursing school, is that it does teach you what normal is.
Well, and you can just say, I don't know what this is. I don't know if it's wheezing or stridor or ronchi or crackles or are they fine or are they coarse, or you know, I don't know what it is, but I know it's not normal, and then escalate, right? Like get an opinion. It used to help me so much to read the provider notes, and like in the provider notes it was like, for acute kidney injury, you know, we're given IV fluids and, you know, diuretics or whatever. You know, I'm like, what? But like, you know, for every single diagnosis, I would say like, hey, this is what we're doing. So it helped me understand like plan of care for different diagnoses in
That
like
is a good
an acute
resource.
care setting.
Yeah. I mean, for
that
those
was
on
super
the
beneficial to me.
in like on the admitted patient side, to be able to read those provider notes is a really good resource. I mean, you don't have that in some parts of the hospital, and you won't have that on your brand new patients that come in the door. But reading that H&P and reading the plan of care,
I think as you're saying, like get, like do something more, be around something more. Obviously, the more you do something, the more comfortable you're gonna be. I know in a clinical setting, my students are always so excited about skills, and that's awesome. And I wanted to do skills too. Whether it was pass meds, IV, give IV meds, insert an NG tube, all of those glamorous things.
That's my least favorite.
But, like the desire, like the learning an assessment's not sexy in nursing school.
It's not. It's not.
And it's not something that somebody's like, I want to be a great assessor. If somebody starts an IV, they tell every single person in the nursing school, and they wear a shirt the next day that says, I started an IV in clinical. But it's not like, Is
that real?
No, but I mean, like, really it should be like, I heard wrong guy and I know the treatment, or like...
No, I do think
the assessments, having a really good ability to assess, that's what's going to get you all of those skills later in life. It's what's going to help patients the most. It's what's going to make you a better nurse. And I think when we say, you need to be doing something continuously to get better at it, I think it's uncomfortable for new nurses to go in there and interact with patients. I don't think a lot of people have worked in hospitals before. I mean, you're in clinicals and you're in the room with another nurse, and you talk to them, and yes, some of these people are PCAs before. They've worked in hospitals in some capacity, but think we're dealing with patients and like, hey, I'm gonna listen to your lungs. Can I just go down your gown real quick?
Yeah.
I mean, like it's,
I remember that, being comfortable with somebody else's body.
It's weird. I'm just gonna clean off your Foley catheter really quick. Yeah,
that is a very awkward thing in the beginning.
Well, I mean, think about Kroger. Like, I mean, like I go to Kroger and I am like, I'm not engaging with someone at a cash register. I'm going to scan.
I talk to everybody.
That's like a Southern thing, but I guess I'm not from the South. I don't know, but
I'm from the real
I mean,
South.
like you look around and everyone's like texting on their phone. The line for you scans like insane, but like there's all of these other lines open. So like, I mean, we have to just even teach like basic communication skills. So not only like when you're coming to the hospital are you needing to learn like a complex environment and multiple disciplines and meds and all of these comorbidities and how all of that plays and policies and I'm an adult, I need insurance now, whatever, right?
No.
Like all of these different things. And maybe you're working night shift, and you've never worked night shift before. And what does that do? And how do you adapt to that? But also like how to talk to people. I mean, we know that, we said previously, like being in the hospital is not a great experience. It's probably one of the worst days of your life. And now we're needing to have somebody that maybe doesn't, we do a lot of communication through text.
Oh, yeah.
Like, your grandma died. I'm really sorry. It's like a text message with a frowny face, let me know if you need anything.
Yeah.
And now it's like you're hearing that in person. So like, working on your
I think
ability to
our
empathize
generation, we didn't always have, we didn't really have text. I didn't get my first phone until I was like 13. And that was like the original Nokia that could
flip
be
phone.
used.
I want that phone.
No, it was before the flip phone even existed.
I want a Nokia. I'm
addicted
addicted to my phone.
Yeah. So, we didn't have the text message. We had it, but we could only do it
if you want to hit C.
Yeah, you had to hit,
the button three
times. Yeah, and then
I know an IV pump like that.
Text messages were only free after 9 and on weekends, so
the bills.
We didn't really have friends during the week.
Yeah, that is a thing. I think text messages actually were free at the beginning of time, and then they realized they could charge for them. So
and then they charged a lot, except for after 9 p.m. on weekends. So on the weekends, I had lots of friends, and I was real busy not playing Snake. Monday through Friday. In the regular hours, all I could do with that phone was play Snake, or call my parents for emergencies.
This is very informative.
Did I tell you about the time I flushed a phone down the toilet at my high school?
Does this involve nursing?
No, that's a story for a different day.
I didn't know if it was like an AD story.
My dad remembers it. I'm sure he's going to laugh when he listens to this. Okay. So the other thing that I wanted to discuss, the complexity of the system. I think that was a really shocking thing for me as a new grad, is like how difficult it is to get people resources. I feel like it is. I mean, we have like a whole position in the hospital and their whole job is to, plan for discharge and the resources that the patient's going to need on discharge.
You're talking about case management,
correct,
social work.
Yeah. So like they have to coordinate with insurance and things get turned down. And I'll be honest, I don't know a whole lot about insurance and payers and all that kind of stuff.
Zero idea.
Yeah. So, I mean, and that's one of my favorite things about my job is it has nothing to do with money. Because I don't know how much, I mean, I could put an IV in somebody. I have no idea how much they're going to charge for that IV.
I think that it's probably nothing, but
probably not.
I think it's included in the room.
Maybe it is included in the room. See, I don't know what's included in the room. So, but I just feel like the system itself is very complex. I mean, I did some time working in the rehab setting, like inpatient rehab, acute inpatient rehab, and the complexity of trying to get patients there for the resource. We had great resources that we could provide to these patients. I mean, physical therapy, speech therapy, occupational therapy, like it was excellent. I mean, it was a good environment. People were going to therapy for at least 3 hours a day. People could really make major improvements and get back to their previous level of function. And then, so I feel like we were doing amazing things in that setting. And then, and even at our current facility, we provide that as well. But it's really hard, I think. I noticed that, like, especially when you're trying to deal with insurance and stuff, like, it's hard to get people from A to B. Like, somebody who we know, I mean, we can look at them and assess them and see they clearly need those resources. But trying to prove that on paper so that it could be approved, was just like, it's wild. So for me, like, I think the complexity of the system, I had zero knowledge base.
Well, and it's weird because like that patient that you're talking about, like that patient no longer needs acute care. Mm-hmm. So, they're sitting in an acute care bed in a pretty big city with a ED that's pretty full and all of these
somebody definitely
hospital
needs that
patients
bed.
that want to come to us.
And they need resources.
And they're just hanging out. So
and it's not safe for them to really go home because they need
they can't go home.
Yeah. Right. I mean they don't have the help they need at home, and they need to get stronger and stuff to go back.
I think a really important part of, so you brought up all of the different services. So I know that this was like a different situation about like patient needing to leave the hospital and go somewhere else, and how complex sometimes the financial aspect of it and insurance and all of that mess. And I'm glad that I don't have to understand that or to know it. But multidisciplinary rounding.
Oh yeah.
That is an area that you can learn a lot from. So, rounding with your case manager and hearing those conversations. I run into, like, when I see like providers or like a case manager or physical therapy going into a patient's room, I always want to be in there if I have time, because I want to know what that conversation is. Also, I want to make sure that, my patient that's like, I don't know this. I want to be like,
never seen a doctor.
You said, well, there's that too. Yeah. But I want to be like, you said you were going to ask them about this, going back to the, here's a paper and pen, write down these questions that you have for me at 3:00 in the morning, the 25 questions. And let's make sure we get them answered tomorrow, because it's got to be overwhelming to, have
as
10 people come in.
Complex as it is for us who work in it, it's infinitely more complex for the patients that are having to navigate it. And that's a role for nursing, is to advocate for your patient and try to help them navigate things as best we can. So, all right. So on to the question I had for you. What really surprised you the most during your first few shifts? Can you think back? Can you remember anything that maybe like really shocked you?
Oh my gosh, probably having to give a report. I don't know.
Was it scary?
Terrified. I had never done a full clinical day. Even I was part of a extern program. So like the summer before you graduate, you're working full shifts, but I think I was always like, oh, I'll do it tomorrow, or I'll give a report tomorrow. I had never seen, in all of my clinicals, I'd never seen like the taking of the patient in the morning and then what that report looks like 12 hours later. You know, it's like the summation of everything that we did today, you know, whether it's updates because that nurse is coming back, which is everybody's favorite thing. That's like the best part of reporting. It's like, and you're back tonight, right? You're back in the morning, right? It's like, it might as well be on the report sheet. But I don't know. I think report was difficult. You know, I'll tell you that I'm the biggest proponent of bedside shift report in the world.
Right. But you also probably give like one of the most thorough reports I've ever seen. Like whenever and you expect the most thorough report in return. I have seen you give report and I have seen you receive report.
Well, I'm not going to take report unless I'm in the room and we're looking at the patient. But I mean, to be
which is
clear,
good. That's best practice. So let's be clear.
We need to be doing it.
Bedside shift report is best practice.
When you are getting report on a patient and the nurse says, "Oh yeah, they've got a wound. It's kind of on their belly button, but on their back, and it's circular, but it's square." And can we just go look at it, Molly? Like, Molly, let's just go look at it, and then we can both actually say that we saw it today. Like, let's not talk in terms.
While we're there, let's go ahead and change the Meplex.
Yes.
And let's
just assess
it.
If you're struggling to tell me where it is and what it looks like, you know, I'm not sure that you've seen it, or I'm really interested because it sounds mythical,
circular, squarish.
Yeah, something like that. And the dressing's kind of like this, but kind of like that. Yeah, let's just all go look at it. Yeah. But I mean, it also helps me gauge. You know, getting a report on 5 patients, and I get stuck in a room for an hour and a half. I know Bob and the first room is okay. I know everyone was okay because I saw them during report. You know, I know that I've gotten a report before and like wanted to throw my papers because I'm like, oh my gosh, this patient's a mess. And this was before bedside shift rounding or bedside shift report, whatever it is. And then that was the easiest patient of the night. You know, so actually being able to see the patient and have that, you know, I have anxiety. So it's a little bit of somebody like introducing me to someone, like kind of like the handoff, like, here's Luke. He's taking care of you tonight.
Here. Real sorry about your luck.
No, but it seems it's like an N, you know. I don't know.
It is like I mean, that's a good way to look at it. It seems
like somebody's like introducing me as like a friend, you know. I don't know.
So
it just eliminates some of the hesitancy that I have.
What's your tip, like, you know, for the next person who comes through and is going to be really nervous for something to give report? My tip would be use your S-bar. Like, use your S-bar. It makes sense. Like, it can be very helpful.
Yeah, and try to use the same report sheet that everybody else is using.
Oh, yeah. A lot of places, I mean, you know, we see it in our hospital. Like, we see a lot of floors have a standard report sheet based off of, like, the type of patients that they typically see, things that they're, so, and, you know, if you have that standardization, and it's usually built off of the S-bar. And
well, I mean, because we learned in school off of like a different report sheet that was like multi-system with like these boxes, you know, whatever. But I, you know, like in a clinical setting, I tell my students, I'm like, use the report sheet that the hospital is using, because they're going to go in like the systematic order from box 1 to 2 to 3 to 4 to 5.
They're going to be filling out a new one. Yeah.
And that's not the way yours looks like, because I know we tried to switch over to an electronic report, and they were like mandating it. They were like, oh, you can just print it off. All the new updated stuff is on there. But there was such a resistance to flip to it. So people that were rule followers were flipping to it, and the other people that were like very resistant to change were not flipping to it. And, you know, I would get report on a patient, and I was so busy like looking for the section that they were on, like when they were giving me a report, like, you know, like they're giving me like respiratory. I'm like, where is it on this sheet? Because we were not in the same format. We didn't have the same flow. But at the end of the report, I felt like I knew nothing about the patients.
Yeah.
Like it was like, oh, well, we had a conversation, but geez. So.
Okay. So just, you know, we're at, you know, almost our full-time limit for what we wanted to do for an episode. And we really have only made it through the first 2 topics of this episode. So we I mean, honestly, we have a lot to say on this topic. Obviously, what nursing school didn't teach you versus what it did teach you, and what to expect whenever you first get out into the real world. So I think we want to make this a 2-part episode.
But I think this is a good time to say, like, hey, like, what else would you like to see in the next episode, part 2? So obviously we have 4 more bullet points, and technically we're only, when we timed this out, what we've said so far was only 8 to 10 minutes of information.
And then we ended up just really like expounding on different thoughts and making it, so much more. So like I said, we have a lot to say. We have a lot to say, and we want to dive deeper. So we don't want to make the other topics that we want to discuss, we don't want to make them small just to fit them in. So making a 2-part episode would be so
give us some feedback, and how do we do that?
So let's give us some feedback. We have our email address, codebrewpodcast@gmail.com. We also have Instagram, and we have Facebook. We have Facebook pages, a Facebook page and an Instagram. And then, and just so y'all are aware, we are now available on multiple podcast platforms. We're on Apple Podcasts, we're on Spotify, we're on Amazon Audible, and then, of course, on Podbean, who's hosting us. So, key takeaways for this episode being, every nurse has been in your shoes, and we've all been new, and we're here to help you. I think that's what Luke and I are here to create a safe space to make you feel empowered to ask questions and learn some new things. And so anyway, like I said, my name's Joe King. I'm here with Luke Warm. This is the Code Brew podcast, and we just want you to stay caffeinated, stay curious, and we'll see you next time on Code Brew.
See you next time.